So we are here to address the management of acutely intoxicated patients and how that might be different in a trauma scenario. So Jenna, can you tell us a little bit about the trends that you've been seeing with some of the newer drugs of abuse?
Sure. So common things being common, heroin and prescription drugs are still a big problem today. However, we are seeing some newer drugs and some old drugs that are making a big comeback. PCP is one of the examples of an old drug that's making a comeback. Often these patients are very out of control and place themselves in very dangerous situations, and they don't have the perception of pain, so they can be very hurt and not be aware. Molly is another drug that is supposedly the very pure form of MDMA, which is ecstasy to everyone who knows what MDMA is. Molly can cause severe hyperthermia. Krokodil is another interesting drug that is mostly found in Russia and Eastern Europe. And is very important to be aware of because of the ability for this drug to, when injected, cause severe soft tissue necrosis.
Okay. So Travis, tell us a little bit about these synthetics that we're hearing about and some of the trends that we see with them.
Absolutely. So this group of synthetic drugs that we talk about is really a very heterogeneous group of drugs that ranges from the synthetic marijuana that we've seen for a while all the way up to this group of drugs that are generally called the bath salts. And in general, the important thing to remember about this whole group of bath salts is that they are stimulants. So a number of these drugs look very similar to amphetamines and methamphetamines in terms of what they look like clinically, whereas some of the other ones look a little bit more like Molly or ecstasy, where they have a little bit more what we call the serotonin side effects to them. The important things to remember is that all of these folks who are on these medications or these drugs are going to look very stimulated, agitated, in some cases quite psychotic, and often they're going to have some severe psychomotor agitation that requires some immediate control.
So some of the common presentations, it sounds like you've touched on agitation and things. Can you elaborate on that and how else we might manage these patients?
Absolutely. So there's a couple of very important management points with these. When folks have taken bath salts, seizures are rather common. You're only going to know what drug they took based on what they tell you they took, and we never really know what that is. So if you see it and you see a syndrome that looks like one of these, you need to treat really aggressively to avoid seizures, hyperthermia, which can be very severe in these patients, and the psychomotor agitation that's going to cause things like rhabdomyolysis and increased body temperature. So that management generally includes, as a first line, benzodiazepines, and we're not talking general sedation doses here. We're talking relatively heavy doses of benzos in order to control them.
Okay.
That's first line. Some of these patients are also going to require some adjunctive measures as well to control their agitation.
Now, I feel like I've been taught in the past that ketamine was something unsafe to give to someone who I suspect has a traumatic head injury. Is that true, or can we be using this more often?
So the short answer is yes, that you can use ketamine in a patient who you suspect a head injury in. Everyone has been taught that we should stay away from ketamine, as very old studies have shown that it may increase ICP. However, if the patient is very violent and a harm to themselves or a harm to healthcare workers, there are some newer studies on acutely head-injured patients which show that it may even increase cerebral blood flow and cerebral perfusion pressures, and that possibly even improved or decreased intracranial pressures with ketamine. In reality, something that decreases blood pressure will probably harm the patient more than something like ketamine, which will increase heart rate and blood pressure.
So besides benzos, what other therapies are available to help control agitation in these patients?
Even though benzodiazepines are still first line, sometimes there's some adjuncts that are needed. Things like antipsychotics, so olanzapine, haloperidol, are certainly reasonable to consider in these patients. The other thing that you may potentially need to consider in some of them is intubation and paralysis in order to actually completely control their body.
What are ways that we should be considering cooling these patients if we do find that their temperatures are going up?
Good question. So when we think about cooling patients that are going to be severely hyperthermic, we need to be doing more than putting ice packs in the axilla. These patients are going to be requiring aggressive cooling measures that may include things like ice baths if they're available, but if they're not available, which typically they're not to us, we need to be using things like fans with misting, or if that's not appropriate in the setting you're in, getting ice water and either icing towels or sheets and actually using those with fans over them to aggressively externally cool them.